कोणत्या कोणत्या लॅबमध्ये करतो ते स्वतः लॅब टेक्निशियन
Good evening, Sneha ma'am. Good evening, Ajay sir. Good evening, Supriya ma'am. Jasmine madam, good evening.
गुड इव्हनिंग मोनिका.
सॉरी मॅम, सगळ्यांना फोन करत 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 4ला 5 कमी झाले.
गुड इव्हनिंग डॉक्टर अजय, सुप्रिया.
Good evening, sir. Good evening, ma'am.
Good evening. Good evening. Hi, Supriya.
Hello, madam.
Hello. 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 Supriya, have you sent me the name of the panelist, what you have given me?
No, madam.
Yeah, that I need to prepare, no? I mean, there's tough time, but I just thought once I will ask you before.
No, we have not made, madam. We'll make it very soon. Very soon. We'll make it.
Yeah, it's okay. I just thought I'll inform you so that, you'll be ready.
Yeah.
Before that,
We
I
have
have lots to do. Almost every day one program at least, one panel at least I have to moderate. And
Yes.
so many things going on, no, simultaneously.
Yes, I think this is something everybody so much, and you too at present you must be doing so many things.
Yes, I have invitations on at least 2 to 3 webinars daily, invitations. And my own is also daily, from 23rd almost daily now. So this week again. So a weekend I have to travel, no?
Yes.
Yeah, last weekend I did Kolkata. Friday, Saturday I did Kolkata. Sunday I did Nagpur also.
Oh.
So every weekend 2 or 3 places to travel. Okay. So
You
this
must be getting less sleep time now, madam.
sleep was always less for me as an obstetrician. It's a heavy obstetric practice, no? But then last 5 years I have really cut down on obstetrics, but still at least something or the other daily. So evening I have, since COVID I have stopped evening. Sleep was always less for. Hello?
Yes, madam. Oh, no.
Somebody. Yeah, somebody, I heard somebody's voice. So, hello, Ajay.
हॅलो मॅडम, काय म्हणताय?
तुम्ही सांगा आता काय म्हणताय.
माझं ना बुधवार गुरुवार इतकं टाइम टेबल शेड्यूल असतं, यांनी बुधवार गुरुवार ठेवलंय. मी त्याला म्हणलं, तिकडून आता मी लॉग आउट झालो तर इथं 5 मिनिटं बोलणार, सुरुवातीला जाणार. माझं विजिट असते ना बुधवार गुरुवार.
अच्छा, सर प्रेसिडेंट सोबत?
नाही, माझे प्रेझेंटेशन विजिट असतं.
अच्छा, हा विजिट असते. मला वाटलं मीटिंग असते. आणि
नाही, मीटिंग नाही.
मीटिंग बुधवार गुरुवार, बरोबर आहे.
मीटिंग आम्ही सगळ्यांना.
सर, एक 2 मिनिटं थांबू, 5 वाजायला फक्त.
हो, काहीच हरकत नाही. प्रियांका नाही जॉईन झाला?
हा सर, दुसऱ्या बाजूला अजून एक PSC मीटिंग चालू आहे, मित्रा मॅडम वाली.
येस,
तिथे आहे सर सध्या. ते पण संपत आले, वोट ऑफ थँक्स देऊन येईल तो पण. गुड इव्हनिंग.
काहीतरी
एक YTP आणि ह्याची फिटल मेडिसिन आपली PSC वाली आणि IISc ची कंबाइंड ऍक्टिव्हिटी होती सर.
उद्या आहे ना?
नाही, , आजच होती सर. शताब्दीचा टॉक होतो ना.
Okay.
Niharika ma'am, good evening.
Hi, hello everyone.
Hi, Nihari.
Hi.
Hello, madam. Hello, how are you?
I'm fine, my dear. How are you?
I'm good, I'm good.
So Niharika is shining, huh? Nowadays I see you very
Oh
often.
no, madam, only because of you. आप जिस वेबिनार में आती इसलिए लोग नोटिस कर लेते हैं.
Come on, tell me. Don't tell me.
Yeah.
But you are a upcoming star. And
No, no, madam. Any plans to come to Lucknow for any CME or any meeting?
you invite me anytime I just drop in. Nowadays I'm traveling on any odd days. Don't I mean
Yeah.
not thinking also. Yeah, so
Good, good,
if
good, good, good. Very nice then.
Ajay
That
sir,
means, yeah.
yes. Ajay sir, Nirja madam will take some time. She is in US, so as soon as network आला की ते join करतील.
हो त्यांच्या
हा,
नातवाकडे गेलेत त्यांना.
मी विधू मॅडमशी पण बोललेत आणि मंजित सरांशी पण बोलले. ते 2 मिनिटात जॉईन करतात. सुप्रिया मैम तब तक स्टार्ट करेंगे क्या?
I think the proceedings you can start because it is.
Yes, ma'am. See, I am just waiting for Ragini madam to join क्योंकि proceeding she has to start with the first lecture, no, ma'am?
So when do I have to join, Monica?
Ma'am, अभी inauguration के immediately बाद we will declare the results and then we start with the academic session.
Yes, because you know
Yes,
that
ma'am.
it's my
Yes,
committee
ma'am.
also today.
Yes, ma'am.
I mean, today.
Ruchir, can we have the introduction slide so that we can start with the program? Even Ajay sir has to join somewhere else.
Sure, madam.
Sure. Can we go live and let me know once we are live so that I can start?
Afternoon. Good evening.
Good evening, Vidhu ma'am.
How are you, Monica?
All
Hello.
fine, ma'am.
Hello, Dr. Sneha. Hello,
Madam,
Dr.
we are
Maninder, Dr. Manjeet.
Hello,
Manjeet.
Dr. Vidhu, how are you?
Good. How are
Manju
you?
sir, good evening. Maninder ma'am, good evening.
Hi, good evening.
Hi, Mandy ma'am. Good evening.
Hi, everybody. Monica,
Hello.
Vito,
Hello, ma'am.
Vidhu, also Sneha, and
Hello,
Manjeet.
madam.
Yeah.
Yeah. Ruchir, are we live now? Can I start?
Yes, ma'am. We are live.
Okay. Thank you so much. Yeah. Very warm welcome to all the esteemed faculty members and the delegates who have joined for this 25th episode of the Public Awareness Committee webinars in association with the Adolescent Committee. Because June is an infertility awareness month, we had started this series with the West Zone 2 months back, and this is the last in webinar on the theme of infertility of this month. This webinar series is the brainchild of our chairperson, Dr. Priyankur Roy. And every month we focus on the awareness months. Accordingly, this month we had the Environment Day and Sustainable Menstruation slogan competitions also. The results which we will be declaring today. I am honored that Dr. Ajay Mane sir and Nirja ma'am have consented to be the guest of honor, and Dr. Jaideep sir has consented to be the chief guest for this webinar, but sir is busy in a meeting. So in case if possible, sir will join later. I request Dr. Priyankur to welcome all our faculty members and introduce Dr. Ajay Mane sir as our guest of honor.
Thank you so much, Monica. So it's indeed a pleasure to have all of you with us today over here. And can we have the lamp lighting initially?
Yes.
Uh,
Ruchir, the inauguration slide, the prayer.
Can we have the lamp
Yes.
lighting before we start, please?
Yes.
शांति शांति
Yeah, may the good Lord bless us all. So I would like to first of all thank all of you for joining us, for giving us this opportunity to be with all of you on this PSC webinars. And currently we are on episode 25, that is the Silver Jubilee webinar that we are having. And it's with our North Zones. We are really lucky to have all of you with us. I really like to thank the FOGSI office bearers, Jaideep Rang sir, Madhuri Patel ma'am, Parikshit Tang sir, and of course Ajay Mane sir, who is like my elder brother, and he has always been so much of a support always. I'd also like to thank Dr. Kalyan Barmade, who has been the previous chair and currently the coordinator, national coordinator, and he is also always a support for all our activities, including, of course, Dr. Monica and Dr. Shatabdi, who does all the groundwork and helps in all the activities as well. I'm really thankful to Anita ma'am, Anita Sabarwal ma'am, and Dr. Vidhu Modgil ma'am for being here. They're the conveners and they've been the North Zone coordinators for for the last 1.5 years and done excellent work with the committee as well. I'd like to welcome the chief guest, Dr. Jaideep Rang sir, the guest of honors, Nirja ma'am, and Ajay sir, and of course the judge for today's competition, Dr. Sneha Bhuyer ma'am. I'm really thankful to Dr. Supriya Jaiswal ma'am, who is my co-chair of the adolescent committee, and she has also very actively helped us in making this competition a grand success. We had a lot of entries. I'm sure Dr. Supriya will tell us about that. I'd like to thank and welcome our speakers, Dr. Ragini Agarwal ma'am and Dr. Jasmine Dahiya ma'am for being with us. And of course, the chairpersons, Dr. Manjeet Singh sir, Dr. Vidhu Modgil ma'am again, Dr. Maninder Ahuja ma'am, and Dr. Anita Sabarwal ma'am. We have an excellent panel today on optimizing treatment outcomes for IUI. And for that, we have Dr. Jyoti Malik ma'am and Dr. Niharika to moderate. And our expert is Dr. Shweta Mittal ma'am today. Our panelists today are Dr. Manisha Bhagat, Dr. Rajni Jindal, Dr. Rakhi Malhotra ma'am, Dr. Rakshita ma'am, Dr. Neeru ma'am, Dr. Seema ma'am, Dr. Manisha Jain, and Dr. Vandana Mohan. I welcome all of you to this webinar. I really like to thank Corona for their continued support towards continued learning. And this is the 25th episode that they support us for the same. Now it's my pleasure to invite none other than Dr. Ajay Mane sir, who I said is already like my elder brother and helps in all the activities in the PSC with a smile. So Dr. Ajay Mane sir is currently the Vice President of FOGSI. He is a medical legal expert. He is the member of NIMC, that is the National Inspection and Monitoring Committee, PCPNDT. He has done medical legal consultations for over 18 years, completely free of cost. And he has been the chairperson of AMOG's website committee, chairperson of sexual medicine committee of FOGSI, as well as the chairperson of adolescent health committee. Overall, as I just say that he is my elder brother, and I wish him all the best for the conference that he's going to do in the coming month, the VPCon in Bhopal.
Thank you,
sir,
Priyankur,
for your blessings, please.
Yes, thank you, Priyankur, and thank you, Monica, for inviting me here. The young brigade is very nicely doing the things, and I am very much overwhelmed that Priyankur is in my committee list. So I'm blessed, basically. So respected Jaideep sir, my co-VP Dr. Nirja, respected Madhuri ma'am, Parikshit Bhaiya, Priyankur, and Kalyan Dada, who is the immediate past chairperson of this committee. These three people, Kalyan, Priyankur, and Monica, they were working very hard since 4 years in previous chairpersonship and in Priyankur's also. They are doing very nice work. So I convey my gratitude and in the names of Judge Dr. Sneha ma'am. I wish all the best to Sneha ma'am for her endeavor in the FOGSI. I urge everybody to help her go in the FOGSI by voting in favor of her. So this is my request. And Dr. Supriya Jaiswal, who is the convener of the competition. And then I endorse the name of speaker, Dr. Ragini madam and Dr. Jasmine ma'am, and the chairpersons, Manjeet sir, Dr. Vidhu ma'am, Dr. Maninder ma'am, and Dr. Anita madam. And the panelist, just a minute, Jyoti Malik ma'am, Niharika Tyagi, and expert Shweta Mittal, both are the moderators. And the panelists, Dr. Manisha, Dr. Rajni, Dr. Rakhi, Dr. Rakshita, Dr. Neeru, Dr. Seema, Dr. Manisha, and Dr. Vandana. And the conveners, the most important persons of the webinar, Dr. Anita Sabarwal and Dr. Vidhu Modgil. And without Monica and Shatabdi, nothing is possible. So I wish them all the best. The topics are very nice. The competition I have gone through, it is very good. And the speakers are also nice. I wish all the best for the webinar and happy learning to all of you. Thank you. Thank you very much.
Thank you, sir, for your kind words and appreciation and for being there always with us. Priyankur,
Thank
can
you.
we go ahead with the result declaration now?
Please do. I request Dr. Supriya ma'am to kindly do the needful because she has really worked hard for the screen as well.
Can we have the slides? Yeah. I am really thankful to Dr. Sneha Bhuyar madam, who has consented to be the judge for the slogan competition of sustainable menstruation. The World Menstrual Hygiene Day was held on 28th of May. Madam has been the ICOG Governing Council member. She has been the past chair of the Breast Committee of FOGSI. She is currently heading the Emergency Obstetric Committee of AMOGS, and she is the past chair of Medical Disorders Committee. We welcome you, ma'am, as a judge, and I request Supriya madam and Sneha ma'am to please declare the results of both our competitions, the Environment Day as well as the Sustainable Menstruation. Ruchir, can we have the slide for the Environment Day competition first? Yeah. This one was each one plant one drive, and the prize would be given to the maximum trees that have been planted, and we're very happy with one entry, which Dr. Supriya Jaiswal madam will read now. The next slide, Ruchir. Yeah. Ma'am, this is the Jabalpur Society slide, ma'am.
Yes. So
Yes,
first of all, a very good evening to everyone present here. And thank you, Dr. Priyanku, Dr. Satabdi, and Dr. Monica for doing such great work in this. And thank you for giving me also involving me in this project in your program, public awareness program that is really doing so good work. So thank you all. And so this is the each one plant one. This Jabalpur Society had done this. And so Monica, do I need to read the whole thing?
Ma'am, the number of plants at least, which is 12 lakhs.
Yes.
It is overwhelming, ma'am, and we could not have a better entry for this competition, ma'am.
Yeah. So the Jabalpur Arts and Guidance Society has conducted a massive tree plantation drive at Sai Krishi farm in this place despite the scorching heat. Trees provide oxygen, absorb carbon dioxide, prevent soil erosion, and support biodiversity. They also improve mental and physical health and provide shade, fruits, water, and oxygen. The doctors pledge to contribute to the environment and inspire others to do the same. So MOGS has collaborated with Mayor Jabalpur Jagat Anu's tree plantation drive to plant 12 lakh trees in next 4 months in 12,500 acres land with the aim of making heart of India, Jabalpur, more greener. They have collaborated with 320 tree plantation companies and many NGOs, and almost each and every citizen of Jabalpur has collaborated with him for the massive drive. They are going to use the Japanese technique for tree plantation, Valmiki technique. Plant will be watered, nourished, and nurtured under CCTV control, and in the control, and it will be in the Guinness Book of World Record has been applied for the same. Then this drive will continue throughout as monsoon has delayed. So we are waiting for it to approach. MOGS have also collaborated with Kadam on an NGO which does tree plantation and also takes their care. So we have tree plantation drive with them on 7th of July, where we are going to plant trees in various government colleges. So we planted many trees on individual basis at our houses, clinics, and farms. So great achievement by this Jabalpur Arts and Guidance Society, and they have really made a history by planting 12 lakh trees. So congratulations to all of you, the whole team, Jabalpur Arts and Guidance Society. So thank you. Over to Monica.
Thank you so much, ma'am. I would now request Dr. Sneha Bhuyar madam to please throw some light about what it was like judging the slogan competition for sustainable menstruation, ma'am. Your views regarding the entries, ma'am, please. Sneha ma'am.
Top speaker.
Hello.
Yes, ma'am.
The topic.
Yes.
Also,
A very good evening.
to
A
chairperson.
very good evening to one and all. My thanks and regards to President FOGSI, Dr. Jaideep Jang
Ruchir, can we have the slides, please?
and Madam Madhuri. Thanks and hearty congratulations. Hello. Hello.
Sneha, yeah.
Ma'am, we can hear you.
No.
Monica, can you hear me?
Yes, ma'am.
Yes. So a very good evening to all of you and my sincere thanks to President FOGSI and of course Secretary General FOGSI. Hearty congratulations to Dr. Priyankar and Dr. Supriya as chairpersons and of course the hard work of Dr. Monica Shatabdi and the entire team. I would like to congratulate the winners and of course would like to just say a few words on the sustainable menstruation that we're talking about the menstrual hygiene and of course the sustainable menstruation. So it's nothing but to have an option for the better, better measures to maintain the menstrual hygiene. And of course, it should be easily available, cost effective and eco-friendly. So it was really very difficult to judge all those posters and slogans, but there is I really appreciate the talents of all the Foxians who have actually designed and prepared their own slogans. There are some in Hindi and some in English. I really appreciate all the efforts and may we have the declaration of the results, Monica, if you can display.
These are the certificates, ma'am, that we will be distributing to the participants, ma'am. The next slide, please, Ruchir. The next one.
Mentioned. Yeah.
Yes.
Yes. So this is use cups or pads, reliable and reusable, make menstruation green and sustainable. So this is so nicely designed and even the slogan is so good. This is done by Dr. Taru Chaya, a dear friend from Jaipur, and I mean really we need to appreciate her and a round of applause for her. She's got the third prize. We can have the next one, Monica. This is by Dr. Suvarna S. Bhopare. The slogan is in Hindi. माहवारी नहीं है बीमारी, इससे क्यों घृणा करती है दुनिया सारी, रखना है स्वच्छ खुद को अब की बारी, पढ़ने ना देना रूढ़िवादी सोच को भारी, हक से मांगना पैड अगली बारी, अब ना बनना पिछड़े सोच के मारी. I think very nicely, well thought of and well put in words also. So hearty congratulations, Dr. Suvarna, for receiving the second prize. Can we have the next one? And of course, the winner, Dr. Anita Gautam from Kanpur. माहवारी है ईश्वर का वरदान, हम महिलाओं की है शान, हम रचते हैं ब्रह्मांड सारा, स्वच्छ पेड़ है अधिकार हमारा. So it is such a authentic and authoritative, very convincing way of, promoting the sustainable menstruation, I would say. And I would like to congratulate all the three winners once again, and I'd like to congratulate the entire team again. Thank you so much, Monica, for having me here. Thank you so much.
Thank you, ma'am. Supriya, ma'am, your expert comments.
These three slogans were wonderful, and although they have written in Hindi, it was more clear, and I think they take they take interest in making these slogans. So many entries came, and these three were the winners. Sneha, ma'am, you have really judged so well, but although it is very difficult to judge which one is the best, still the work you have done is very well, because I also judge sometimes many slogans came, very difficult to mark them. So thank you very much, and thank you PSC for doing this huge job and making me a part of it. Thank you so much, Monica, Satabdi, and Dr. Priyanka.
Thank you, ma'am. With this, we declare that the inauguration is over. I thank Neerja madam, Ajay sir, Jaideep sir for joining us today and blessing us. I also thank Sneha madam for joining us as a judge for the competition. Can we move forward with the academic session now, please?
Thank you, Monica. Thank you so much once
Yes,
again.
thank you, ma'am.
Yeah, and I just make an humble appeal to all of you to support my candidature and vote for me. The voting is very close from 1st to 10th August. So support my candidature from West Zone, Dr. Sneha Bhuya. Thank you so much.
Sure, ma'am. We all are with you, ma'am.
We all are there.
Thank you. Ruchir, can we have the slides? We will start with the academic session now. The first talk is Aesthetic, Functional and Regenerative Gynecology, the newer treatment methods for infertile patients. This talk would be given by Dr. Ragini Agarwal, madam, and our chairpersons for today's session are Dr. Manjeet Singh Sidhu, sir, and Vidhu, madam. Can we have their CVs, please? Dr. Manjeet Singh is the director of Preet Hospital, Bhatinda. He is currently the president of Bhatinda OBGY Society, and he has also been a part of the AFMC Pune. His special interests include advanced vaginal and laparoscopic surgeries, and he is a member of various organizations. We welcome you, sir, as a chairperson for this session. Our next chairperson, Dr. Vidhu, madam, is also the North Zone Coordinator for the Public Awareness Committee and the convener for this program. She is a director and senior consultant at Suman Hospital, Ludhiana. She is also a gynecologist and infertility specialist. She is a lifetime member of various organizations, the past president of Ludhiana OBGY Society. She has many awards to her credit, and she has undergone training fertility at IRM Calcutta under Dr. B.N. Chakravarti and the FOGSI recognized ultrasound courses. We welcome you, ma'am, as a chairperson for this session. I request Manjeet sir to please introduce Ragini madam and Vidhu madam to please then conclude the talk. Sir, can you please see the slide, sir?
Yes.
Yeah.
Good evening, everyone. Our next speaker for the day is Dr. Ragini Agarwal. She is director of Derma Science Complete Clinic for Women Health and director of Department of Obs and Gynae Cloud9 Sector 47, Gurgaon. She is the founder and president of Indian Society of Aesthetic and Regenerative Gynecology, founder and president of Indian Academy of Cosmetic Dermatology, and founder president-elect North India Gynae Forum, founder chapter convener of AID-MWI Gurgaon, general secretary-elect IMS, vice president FOGSI 2020, founder committee chairperson Aesthetic Health Indian Menopause Society, founder president Association of Obs and Gynae Haryana. She is national chairperson of Public Awareness Committee and founder secretary of IMS Gurgaon chapter, national convener of Indian Menopause Society, and patron Gurugram Menopause Society, chairperson of Public Health Education and Awareness, Lions Club. So I request Dr. Ragini Agarwal to kindly give her presentation.
Am I audible?
Ruchir, please madam to share her screen and stop sharing your screen, please.
Yeah. Madam is not audible.
Madam.
Hello?
Ma'am, you're audible now.
Okay.
You are audible, but voice is low.
वो तो थोड़ा बहुत इंटरनेट की प्रॉब्लम चलती रहती है. Thank you so much, Monica, Supriya, Priyankur, for giving me this opportunity, and especially I'm seeing Vidhu, my very close friend. Hello, Vidhu, and I will start my presentation for today.
It's always an honor to listen to you and learn new things.
Just make it full show. So when this topic was given to me, we talk about this aesthetic, functional, and regenerative gynecology in infertility, the first reaction was, what I'm going to talk about the infertility. Because when we usually talk about the aesthetic, functional, and regenerative gynecology, mostly we think of the woman postpartum, 40 plus, menopausal, which they require lots of redo surgery, redo cases in them. Yes, regenerative gynecology as such, when we think of the infertility for the ovarian regeneration or endometrial regeneration, it comes in our mind. That is altogether a different topic, not directly related to this subspecialty. But when I thought about it, there are so many things we can discuss even in terms of the infertility also. So with blessing of God and gratitude to each and everyone who has made me here, I'll start my presentation. Today what we are going to talk about, the word aesthetic, functional and regenerative gynecology is something a very new word. What is its component and how it is helping women for their quality of life, maybe an infertile woman, and why the initial word cosmetic gynecology should be dumped in a dustbin. It does not do any justice with the subspecialty, but it's a misnomer, it misguides people, and it is really a frivolous term to absolutely not use by a professional educated doctors the word cosmetic. And how knowledge of this field can help the infertility. Let's discuss one by one to all. When we talk about the aesthetic, the moment we use word aesthetics means a beautification. Here you are nobody. You are just what the patient wants. So directly, indirectly, we are not having anything about any issue, real issue of a woman when we talk about the aesthetic medicine. It is unique to each patient. The type and the extent of each treatment varies based on the level of correction. Patients do seek aesthetic doctors, and it is for their self-confidence and feel to comfortable in their skin. But the moment we add the word functional gynecology, the picture changes. Here is a woman who is suffering silently. Maybe it is a menopausal problem, maybe it is a postpartum problem, maybe she is an infertile patient. She is a silent sufferer. And here there's some functional issue which we as a clinician or a physician has to address and stop their struggling. So the functional gynecology is a branch of the functional medicine which aims to address the underlying true cause of disease, empower the female body and promote the optimal wellness. It does not focus merely on the symptom, but employs novel diagnostic tests and through medical history questionnaire to analyze each patient biochemical, metabolic, genetic, and the lifestyle factor, and then compile a personalized therapeutic plan that will not only alleviate the symptoms but treat the real cause of disease. And when we come to the third part of this particular subspecialty, that is regenerative medicine, then it is an interdisciplinary field which health science principles are applied to restore diseased and or injured tissue and the organs. So, dear friends, that's why here we use the word aesthetic, functional and regenerative gynecology, and we address the woman health, not disease. We address for the quality of life and woman as an individual, not a vessel to procreation. So how we can apply this in infertility? The question is that when we talk about the aesthetic, my whole journey, my own whole journey has started in 2000 for the labia correction, a labiaplasty of a woman who came to me. And when I tried to do PV, the labia is so big, it is really a difficult per vaginal examination. When she saw me little bit struggling, she said me, Doc, I am unable to have a regular intercourse because of this. Do you have some remedy for it? At that time, there's no one knows what is a labiaplasty or not. I said, look, I can do something, although I don't know whether it should be done or not, or where it is written and what it is called, but I can help you. if you think that I'm not doing something bad upon you. So I just trim the labia, stitch it, and she came back pregnant after 6 months, because then they have able to have a regular ultrasound, a regular intercourse, and they have a regular life without stress. So when we talk about the aesthetic gynecology, the only thing which comes in my mind is a hypertrophic labia as a topic. Other things, what we do in the aesthetic surgery, they are not directly related to the infertility. But when we talk about the functional gynecology, there's a many things which we can discuss, like vaginal health. Vagina is the main sexual organ and the way to procreation. If there's any problem in the vagina and its health, we have to address. And even the persistent infection can be a reason of infertility. Maybe a persistent E. coli infection going to inside the uterus, leading to the tubal infection and causing this ascending infection. But again, I'm not going to talk about in detail because it is a general gynecology and we all read about it. Yes, there's something which I want to talk, which we usually not talk. We are not even advised to ask even to the sex history of a patient during our PG days, UG days, when we used to take all the history, family history, personal history, drug history, blah, 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 blah. But ever any of us has asked about the sexual history? No, never. And you will surprise. Once I was giving this talk to somewhere that sexual health matter as a quality of life, a very senior person came to me and he told, when the patient came to me for as an infertile patient, I have given her, after seeing everything, for 3 months treatment as a ovulation induction. And then I asked her to come for the IUI. And when I tried to do the examination, I was unable to do it. And she told me I'm unable to have a regular sex. She is suffering from what is a sexual dysfunction, that is genital penetration disorder. Yes, friend, today with the help of this functional gynecology, the latest treatment, we are able to solve many cases. Now, regenerative, as I have talked about you, that the patient of the premature ovarian failure or a thin endometrium, we are all using PRP, stem cell and everything for the ovarian regeneration and endometrium. So again, I'm not going to talk about it. It is altogether a different ball of game. What I am going to focus myself is what I talked about in the hypertrophic labia, where there's a difficulty in the penetration. Those are the patient, if they ask you for the problem, or you see this is some reason, you can offer a minor labiaplasty. But most of the cases, we are never offer any patient for the labia minoroplasty until unless she really need it. But as I have quoted you, this particular case might be some patient, because of this having a infection, having a chafing, having a low steam and a stress, not a regular intercourse, they can be having a problem, may require a labiaplasty, which is a very, very simple operation for all of us who are practicing day in out very, very difficult labia surgery. So what has changed the scenario? Why we are talking today about this thing? The two things has come. One is the energy-based devices, which is one of very, very big tool for all these functional and regenerative gynecology. It has nothing to do with the aesthetic. And the second thing is the adjuvants in the form of Botox, form of PRP, form of stem cell, and many other things like exosomes and other things. And with the use of these products, which are basically is going to be a part of the regeneration or going to address some other problems, can help our infertile patient to get pregnant. So evolution of the non-invasive medical aesthetics has changed everything. The first laser, although it has come for the aesthetics in 1990 in the dermatology, but when they come in the use of a gynecology, their whole perspective has changed. Because here, we are not going to address any wrinkle formation, any sagging sagging. But what we are going to do with these things, they are much, much beyond that. We are addressing day and night so many disorders which we don't have any answer with us. And the menopausal woman, specifically after cancer, the early menopause patient is having lots of problem. There we can have a laser induced regeneration in the vaginal canal, and only then patient can have a regular sex and can become can have lead a regular life. But how it is going to affect the infertility? Let's move on and see. So this treatment using energy-based devices, what it does? It was FDA approved for what? Incision, excision, ablation, vaporization, coagulation of the soft tissue in the body, in the field of dermatology, gynecology, neurology, everywhere. And GSM is even highlighted that you can do by this. So what they do, they destruction of the abnormal cervical tissue, vaginal tissue, condylomata, precancer lesion, these are allowed. If they are allowed, these things are allowed, we can do the vaginal regeneration also, which is a very, very simple procedure. It does not cause anything. What does it do is thickening of the non-keratinized epithelium, increase in the local angiogenesis, improvement in the lubrication, normalization of the genital microbiome, decline in vaginal pH, development of the new collagen fiber, and improvement in the genitourinary system. So they are all based on the physiological modification of the human tissue. They are basically thermal heat causing the 40 to 42 degrees centigrade thermal changes leading to the denaturation and causing of collagen contraction, neoplastosis, vascularization, growth factor infiltration to revitalize and restore the elasticity and the moisture of the vaginal mucosa. We all know that laser is a type of energy. Electromagnetic energy travels in waves and spans a very broad level like this. But here we are only limited to certain wavelength which are mostly in the infrared range. They don't cause any harmful effect as they do not cause any non-ionizing radiation to the patient. So it is a low energy emission and mostly RF, microwave, light-based technology, heat is the result in the common pathway. So why I am talking about this? Because these two disorder, vulvodynia and vaginismus, which can be a cause of infertility, maybe because of the non-consummation of the marriage or not able to have a proper intercourse. These two problems does not have too much answers with us. They have a whatever the treatment is there, they are not mostly very successful. With the introduction of the EBDs and the Botox in the vaginismus has changed the scenario completely. So what is vulvodynia? We all know it is a pain in the vulva persisting for at least 3 months in the absence of an obvious underlying cause, severe pain on vestibular touch or attempted vaginal entry. The pattern can be continuous, intermittent, cutting, burning. Location may be localized, generalized, mixed. Condition that provoke it contact is spontaneous or mixed, and it may be primary or secondary. So greatly impacts both the quality and the frequency of the sexual activity, and the frequency of the sexual activity is directly related to the infertility. So here we use fractional carbon dioxide laser. In many cases, it gives a wonderful result. What we do, a topical lignocaine, then we use a light aesthetic mode, and these are the setting in my machine. Maybe it is different in some other machine. Recording. Now the second thing which I use in these patients is basically pelvic floor muscle therapy. That is by a electromagnetic chair where patient has to sit and almost 7 or 8 sessions of the electromagnetic waves are sent inside to give a pelvic muscle exercise, increase the vascularization. Here we are not touching the patient at all. And patient is just sitting and the waves are going inside. So it does not causes to any problem to the patient also. Then we take this fractional carbon dioxide laser. Even for the chronic pain, the lasers are used by the physiotherapist and the functional specialist for anything from fibromyalgia to the BPS, that is the bladder pain syndrome, and from where we have picked up for our this vulvodynia also. And also in the cases of the after giving over the vestibule, I go inside and do it on the inside of the vestibule also with the family probe, and in the internal part with the activation and the three clock position of the 3, 6, and 9 degree. Same. So the probable mechanism is a photobiomodulation. The low-level laser therapy is highly effective for pain relief and the tissue nerve repair, which is seen in many specialties. Often patients who have been in constant pain for many years experience instant pain relief, which traditional medication has been unable to address. Low-level lasers has no side effects. They work at 3 fundamental levels. Lymphatic system encourages the distribution of the white blood cells. And here what we think of the stimulation of the ATP and the collagen production and promote nerve repair and the fresh tissue growth, which address the cause of pain. In my 12 patients of the vulvodynia for different reason, maybe primary, secondary, maybe because of the operation, they all responded quite well with the laser treatment. Now coming to the second part of the talk, that is the Botox. We all know that Botox, botulinum toxin, is a neurotoxin produced by the Clostridium botulinum. Type A is approved. So prevention of the acetylcholine release prevents neuromuscular transmission, muscle weakness, and temporary muscle paralysis. Other pathways in the sides Botox affect is autonomic ganglia, postganglionic parasympathetic nerve endings, sympathetic nerve ending onset, and 3 to 7 days post-injection, duration 3-4 months. So what we do, if we see, this is now called the levator ani syndrome. Here the levator ani is in a spasm. And whenever you try to enter inside, it will contract like a board-like structure, and it is very difficult to do. We offer so many things to the patient to do the vaginal dilatation, this and that, but the patient coming to you have done everything. And here, when till last 4-5 years, we have started Botox. It's a wonderful thing. We dilute the Botox and almost we give 150 to 250 usually units injected to the puborectalis muscle and the levator ani muscle on the down. And we have to avoid the 6 and the 12 position because it can cause the temporary paralysis of the urinary tract and the anus and can cause an involuntary leakage of the urine and feces. That we always tell the patient, although it never happens. But once we put this injection in the patient, and when the patient is awake, she came awake with a big mold inside and not causing much of the pain. And gradually, they have a regular intercourse. The patient does not really feel anything. And with that, she has some psychotherapy also, and she responds very well. Almost 90% women do not require another set of the injection. So indication for this is a severe or mild refractory cases. Contraindication are hypersensitivity to albumin, botulinum toxin, infection, pregnancy, disease of neuromuscular transmission, coagulopathy, or the therapeutic coagulation. No major side effect, fecal incontinence lasting 3 to 4 months, unusual pressure pain in the vagina, separate from the vaginismus pain. So this AFR gynecology is a new developing specialty with new indication, but need more and more publication, and not only more and more doctors should understand and make it a part of their routine practice. It is not something which is elusive, which is something for very niche of the patient. Yes, when you talk about the cosmetic gynecology and demeaning this particular wonderful subspecialty, then yes, you may need a niche patient for the vaginal plasty, clitorodotoplasty, and all those pleasure shot and all. For that, our most of the women is not going to come to you. But when we talk about the fertility and gynecology, there is no dearth of the patient with you. You can use in the infertile patient, you can use for the postpartum regeneration, and you can use for your patient in a end of their life, the second part, that is a menopausal. So we all have a dreams. I am here to inspire you to achieve them. We need to have the courage to step out of our comfort zone to achieve our dreams and create a new achievement in our lives. Thank you so much for your patient hearing.
Thank you so much, Ragini ma'am. That was a wonderful lecture. I would request Vidhu ma'am to please give the concluding remarks for ma'am's talk.
Thank you, Shatabdi, for this, and thank you, Monica, for inviting me for this. And Dr. Ragini, ma'am has already, said everything about this. What is the newer in vaginismus and vulvodynia, how these procedures can help us to improve this and maybe improve our fertility rates. Sometimes we usually see in our practices also, a newly married couple comes to us and they're just having vaginismus, and that could be the reason for her infertility. But counseling and all these treatments definitely play a great role to overcome them. And we would definitely, we have, take a note of whatever ma'am has said, and we would apply in our practices. Thank you.
Thank you so much. Thank you.
Thank you, Vidhu ma'am. Thank you, Ragini ma'am, once again for the wonderful talk. We will now move on to our next session. Our next session is another important topic, very pertinent topic in today's times. It's polycystic ovarian syndrome and its impact on infertility. The talk will be given by Jasmine Dahiya ma'am, and we have Dr. Maninder Ahuja ma'am and Dr. Anita Sabarwal ma'am as our chairpersons for the session. Can we move on to the slide, please? Yes, it's my ultimate pleasure to welcome Dr. Maninder Ahuja ma'am. Ma'am is the president of the Society of Meaningful Life Management. She is indeed a very inspiring and motivating personality. She has more than 50 years of experience in holistic healthcare of women. She has more than 130 publications in journals, textbooks, and as authors and editors, and is very, very active and always inspires everyone. Our next chairperson is Dr. Anita Sabarwal ma'am. Ma'am is our, yes ma'am, good evening ma'am. Ma'am is our North Zone coordinator, and she has very many awards and multiple books and publications to her credit. Welcome ma'am. I would like Maninder ma'am to kindly introduce Jasmine ma'am, and Anita ma'am, you can give the concluding remarks.
Okay, thank you. Dr. Maninder ma'am, please introduce.
Dr. Jasmine. I think it's a pleasure to introduce Dr. Jasmine Kaur Dahiya, because the new torchbearers are taking over. So it's very, very heartening to see them there. Now they're coming up. And she is the clinical director of IVF consultant, Nova IVF Fertility Center in Jalandhar. And clinical focus and expertise is on IVF and high-risk pregnancies. And she has the designation of member and vice president of Punjab Medical Council and president of ISAR Punjab chapter Punjab, vice president FOGSI Jalandhar, and WD chairperson IMM Punjab. Faculty experience, she has about 3 years as an MO in DMC, 3 years registrar in DMC, and 21 years consultant in Jalandhar. So we welcome Dr. Jasmine Kaur Dahiya, and she will be giving a talk on the PCOS. Dr. Jasmine.
Good evening, everyone. Respected seniors and dear friends, I will be talking about polycystic ovarian syndrome. Just 1 minute, please. First of all, thank you, ma'am, for the kind introduction. And thank you, Shatabdi, for having me here. And I will just give me a minute. I am having some problem with the screen.
Ma'am, this is a older version, no?
Okay.
So older version will not be able to, yeah, slideshow. You can show this only
Okay.
because
I'll go on like this then.
huh?
Yeah.
Yeah, you go on like this only.
Go on like this, yes.
Yeah. So the topic is polycystic ovarian syndrome and its impact on infertility. And if I want to define it, polycystic ovarian syndrome is an endocrine system disorder, while PCOD is a condition developed by the hormonal imbalance. The exact cause of both is unknown, but hormonal imbalances and genetics play a pivotal role. Both are associated with infertility, but PCOD is not as serious as PCOS, which is the more severe form, the syndrome. If I talk about the overview of PCOS, it is a common heterogeneous heritable disorder affecting women throughout their lifetime. It is characterized by hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. Common findings are insulin resistance, hyperinsulinemia, which increase the risk of diabetes and cardiovascular disease. The global prevalence being 2.2 to 26%, roughly 1 in 15 women worldwide, as per Lancet 2007, have this issue. 36% of women in India are suffering from PCOS. WHO estimated that PCOS affected 116 million women globally in 2012, that is 3.4%. In India, the prevalence is reported between 3.7 to 22.5, and 9.13 to 36% prevalence is there only in adolescents. PCOS becoming epidemic in Bangalore city was published in Indian Express 2013 because of lifestyle issues. And insulin resistance plays a key role in the pathogenesis of PCOS. And Indians are known to have high prevalence of insulin resistance. Hence, the prevalence of PCOS is expected to be high in the Indian population. The etiology, a large number of genomic variants has been associated with PCOS, and many of these associations have not been replicated in different populations. It is believed that the picture is of multi-genic etiology in which non-genetic factors such as diet and exercise have a strong influence on the development of the disorder. The diagnostic criteria, we've all read about them. The best one, I would not say the best ones, the one which are commonly followed would be the Escher-SRM Rotterdam criteria 2004. There should be exclusion of other androgen excess or related disorders. It includes two of the following: clinical or biochemical hyperandrogenism, oligoovulation or anovulation, polycystic ovaries. Any of these two would be required to put it as a diagnostic criteria for PCOS. The Rotterdam definition extended the diagnosis of PCOS to women with oligoovulation and polycystic ovaries, which are non-hyperandrogenic, as well to the women with hyperandrogenism and ovulatory polycystic ovaries. There is a schematic diagram showing the main factors involved in PCOS pathogenesis. Pituitary LH secretion is necessary to sustain the ovarian androgen excess, but is not sufficient to cause it. Insulin-resistant hyperinsulinemia acts on the theca cells to aggravate hyperandrogenism, synergizes with the androgen to prematurely luteinize granulosa cells, and stimulates adipogenesis. The increased hyperandrogenemia provokes LH excess, which then acts on both theca and luteinized granulosa cells to worsen hyperandrogenism. LH also stimulates the luteinized granulosa cells to secrete estradiol, which suppresses the FSH secretion. So all in all, the insulin resistance is a pathological contributor to influencing the HPO axis. 90 to 95% of anovulatory women presented to the infertility clinics have PCOS. And once there is a change in the HPO axis, the decreased serum hormone binding globulin is there. There is an increase in ovarian androgen synthesis and an increased LH-FSH ratio. Hyperandrogenism can cause acne and hirsutism. Menstrual irregularity can be there in the form of oligo or anovulation, and thus results the polycystic ovarian syndrome, leading to female subfertility and infertility. Now, if we look at the figures like this, that approximately 85 to 90% of the women with oligomenorrhea will have PCOS, 30 to 40% with amenorrhea will have PCOS, and 15 to 20% of adult women with PCO manifestations will have acne. 90 to 95% of anovulatory women reporting to fertility clinics have PCO nowadays. And more than 80% of women having symptoms of androgen excess present with polycystic ovaries. Hirsutism occurs in up to 70% of women with PCOS, and infertility is seen in 40% of women with polycystic ovarian syndrome. Spontaneous abortion is also seen more frequently in PCOS with a high incidence. The clinical presentation, like I just said, it can be genetics or lifestyle. There will be hormonal changes, increased androgens, increased insulin, and diabetes mellitus syndrome can be there. There can be cardiovascular risk, menstrual disturbances, subfertility, hirsutism, acne, and psychological issues like body image, self-esteem, depression, anxiety, everything just comes along in this syndrome. Just a pictorial representation of all that I have just said. There can be acanthosis, there can be acne, hirsutism, obesity, hair loss also, and infertility. The core issues being insulin resistance, hyperandrogenism, ovulatory dysfunction, and infertility. The overall complications of PCOS across the lifespan in menarche, menstrual irregularities, acne, and hirsutism will bother. In reproductive life, infertility, miscarriages, pregnancy complications are there, and at menopause, endometrial hyperplasia will be seen. And metabolic syndromes like pre-diabetes, diabetes, cardiovascular risk, and even there is a predisposition to cancers. So if I go on to the diagnosis and investigations, there is oligo or anovulation, ultrasound findings of increased ovarian volume, 10 centimeter cube or more, and follicles more than 12 in one or both ovaries. Clinical or biochemical signs of hyperandrogenism is there. An exclusion of other etiologies such as hypothyroidism, hyperprolactinemia, congenital adrenal hyperplasia, Cushing syndrome, and androgen secreting tumors should be done. Lab investigations would be elevated total testosterone, DHEAS, LH-FSH ratio, hyperinsulinemia, and dyslipidemias. AMH is another investigation which is being done to diagnose polycystic ovarian syndrome. If we talk about a high AMH plays an inhibitory role in follicular development and recruitment, contributing to follicular arrest. AMH inhibitory action on FSH-induced aromatase production likely contributes to the hyperandrogenism in PCOS, which further enhances the insulin resistance in these women, as per this study in 2016. Hemostasis model assessment is also done as per this Journal of Diabetes 2011. The HOMA-IR index normal would be less than 3. And coming on to the management, there has to be lifestyle changes. We can try ovulation induction in infertility. Metformin and other insulin sensitizing drugs can be used. Laparoscopic ovarian drilling is to be done selectively, and sometimes IVF would be required. So among the lifestyle changes, weight loss and exercise have a key role. It does not help in hirsutism, but menstrual function is improved with 5 to 10% reduction in body weight. Uncertain sustainability of menstrual cycling or pregnancy outcomes after weight reduction is there. And there is a decreased requirement for the use of ovulation induction or other fertility treatments. Exercise therapy alone or in combination with dietary intervention improves weight loss and reduces cardiovascular risk factors and diabetes risk. And there has to be some preconception counseling. Obesity associated with anovulation, pregnancy loss, late pregnancy complication, everything is counseled. Weight loss is recommended as first-line therapy in obese women with PCOS. Pregnancy after losing a little as 5% of initial body weight is also known, and improvement of spontaneous ovulation rate is seen, and there is also an improvement in the live birth rates. The goals of ovulation induction would be to induce monofollicular development, start with least invasive and simplest treatment option, maximize rate of singleton pregnancies, minimize the risk of OHSS. The medications that can be used for ovulation induction are clomiphene citrate, letrozole, metformin, or gonadotropin therapy. I will not go into the details with clomiphene. We've all used it left and right. And the outcomes being 80% would ovulate and cumulative pregnancy rate 30 to 40%, miscarriage and birth defect similar to spontaneous pregnancy, multiple gestation rate is 7% and very less incidence of OHSS. The duration of treatment, cumulative live birth rates 50 to 60% for up to 6 cycles are also seen. Pregnancy rates are low after 6 cycles. And there is a risk of increased risk of ovarian neoplasms. ACOG limited fewer than 12 cycles and generally should be limited to 6 cycles. The adjuvants being a combination therapy with metformin, dexamethasone, or alternative therapy can be tamoxifen. Letrozole is now being used. Other adjuvants being melatonin, N-acetylcysteine, myo-inositol, alpha-calcidiol, and chromium, and L-methylfolate can also be used. The aromatase inhibitors, we all know the dosage. Higher dose is associated with rather a thin endometrium. In comparison with CC, there is monofollicular development, no direct anti-estrogenic effect, shorter half-life, and lower serum E2. And if I go on to the gonadotrophins and analogs, they are the second line of treatment in case of CC resistant or CC failure. Step up or step down regime to get single follicle resulting in single live birth would be good. Low dose step up protocols recommend a starting dose of 37.5 to 50 IU per day. Ovarian response monitoring is required to reduce complication and secure efficacy. And strict cycle cancellation criteria should be agreed with the patient if the more follicles are developing. And there is a higher risk of OHSS and a higher risk of multiple pregnancies with gonadotrophins. LOD, it can be used only as a method of induction of ovulation and not for treatment of PCOS. Laparoscopic drilling using electrocautery or laser is universally accepted procedure now, aimed with the goal of creating focal area damage in the ovarian cortex and stroma. LOD is usually effective in 50% of women, and additional ovulation induction may be required, and now more so done for when there is other indications of laparoscopy as well. The potential complications include formation of adhesions and long-term side effects of tissue damage or ovarian function. IVF would be the last resort, and ovulation is not primary indication for IVF, and multiple pregnancy rate is 10% after gonadotropin therapy. PCOS women who have associated pathology, IVF is indicated. Induction of ovulation with gonadotrophins would be replaced by controlled ovarian stimulation and IVF. IVF and single embryo transfer, the risk of multiple pregnancies is markedly reduced. Clinical pregnancy rate is similar between PCOS and non-PCOS women. Adjuvant use of metformin may enhance the ongoing pregnancy rate and reduce OHSS. The recent Cochrane review comparing GnRH antagonist protocol with long GnRH agonist protocol, no significant difference was found in ongoing pregnancy rate or clinical pregnancy rate. Rate of OHSS was 10% lower with the antagonist protocol. A randomized controlled trial showing metformin 1500 milligrams per day significantly reduced the risk of OHSS in women with PCOS undergoing IVF. This was a Cochrane data, no conclusive evidence that metformin treatment before or during ART cycles improved live birth rates in women with PCOS. The use of this insulin sensitizing agent increased clinical pregnancy rates and decreased the risk of OHSS. This was another study in human reproduction, October 2011. Published data indicate a significant increase in ovarian hyperstimulation globally. The occurrence of approximately 3 maternal deaths per 100,000 stimulated women was reported. And the syndrome can be erased by applying ovarian stimulation using combination of GnRH antagonist with GnRH agonist to trigger ovulation. And in this case, the strategy is to freeze all the oocytes or embryos for later use. The Endocrine Society Clinical Treatment Guidelines for PCOS. OC is the first line of management for the menstrual abnormalities, hirsutism, acne of PCOS. Screening for contraindication of OC's use via established criteria should be done. Exercise therapy in the management of overweight and obesity in PCOS. Weight loss strategies begin with calorie-restricted diets for adolescents and women with PCOS who are overweight. Metformin is first line of treatment. Metformin is recommended in PCOS who have type 2 diabetes or who fail lifestyle modification. For women with PCOS with menstrual irregularity who cannot take or do not tolerate OCs, metformin is second line. And clomiphene citrate as first line treatment for anormal fertility in women with PCOS. The current management options would be CC, we can use tamoxifen, letrozole, metformin can be used, and insulin sensitizing agents are also being used. Gonadotropin therapy, like I just said, GnRH agonists or antagonists, both are important. Inositols also have a role to play in the management of PCOS. The overall conclusions being PCOS women who desire pregnancy, we should exclude any other health issue or infertility problem in the couple. Preconceptional counseling, weight reduction have a central role. Recommended first line of treatment for ovulation and induction remains CC or letrozole. Second line being intervention with gonadotropins or laparoscopic ovarian drilling in selected cases. And the third line of treatment being IVF. There should be a patient-tailored approach. Metformin restricts to women with glucose intolerance, and antagonist protocol with all freeze is how we can avoid OHSS to a large extent. That is the concluding slide. Thank you for your attention. Thank you, everyone. Thank you.
Thank you.
Thank you,
Dr.
ma'am. Over
Jasmine.
to you, Anita, ma'am.
Yeah. Yes, yes. Thank you, Dr. Jasmine, for the wonderful presentation. It was truly updating, interesting. And incidentally, I just had organized a panel discussion on PCOS weight management. We just, your own chief mentor, Dr. Sonia Malik ma'am was the expert. I'm just coming back from there. That's why I was a little late in joining. And we had a panel of endocrinologist and a dermatologist and a psychologist, along with the gynecologist and IVF specialist. So it was really wonderful discussion, and I enjoyed this presentation so much. I'm just back, and multidisciplinary approach and weight management and lifestyle management, they have a big role. And we also had a yoga person to teach how to go about this. So really, I enjoyed your lecture so much.
Can I add something here?
Sure, Dr. Maninder.
Yeah.
Yes, ma'am.
I think there are 2 or 3 things in PCOS which are very, very important as far as the infertility is concerned. First is the hyperstimulation syndrome. I think that is the nightmare of all the infertility specialists, how to stimulate them. Either they are not stimulated, or when they get stimulated, there are, I think you can see the follicles coming up like a, I don't know, blooming अंगूर के दाने की तरह literally हो जाता है वो. So that is why. So recently what I have seen in my own patients is that what I have started doing, I have tried the letrozole, extended letrozole, and that has helped. even in patients, when we just want to have the IUI and the patients are not affording and they are not ready for the cancellation of the cycle even, so they get scared. So I have tried letrozole and about 4 to 5 decent patients only. The extended use, beyond 5 days, I took them and the ovulation was there. So that is one of the things which I want to share here. Secondly is the weight gain. We all said and done. Practically, what do we advise to the patients about weight, how to lose weight? So what I advise them is just to stop the chapatis and the rice, carbohydrates, because if we take maximum salads and dal and sabji, whatever is seasonally available with fruits, that is sufficient to provide you with the carbohydrates also. So this is a practical advice, because you cannot send everybody to the dietitian. That's not affordable, but practically this is what I'm doing for myself also, because I am also a PCOS patient, to a thin one, but I was a PCOS patient, I diagnosed myself. Thirdly, when I come to the exercise part. How do I advise them exercise? That is very important. So basically, these women or these girls, they need the aerobic exercise. So that means walking. Do they have time for walking? They don't have time for walking. So what they can do, skipping. Skipping at home is the best exercise for them, because can be done at home. If they do 50 to 100 skipping, that covers up the aerobic activity also, and the bone formation activity, which is because of the high impact exercise, that is very useful. Thirdly, what we can do, all of us does as an exercise, it's not a joke. Dance is the best exercise, because when you are not getting time for any other type of exercise, you have 10-15 minutes with yourself, with the music on in your bedroom. Start doing any steps of exercises you can copy. They will give you range of movement, they will give you aerobic exercise, they will give you resistance training. So these points, I think, in PCOS management are very, very important. Thank you very much to organizers for giving this me opportunity. But basically, one thing I wanted to add more towards the cosmetic
पैनल डिस्कशन भी है
regeneration.
अभी पैनल डिस्कशन भी है
Okay. So there is panel discussion, so we are short of time. Thank you very much for being there and organizing this wonderful webinar. And of course, I can see the Jyoti Malik is already there for the part. I missed you.
Thank you, Dr.
Faridabad,
Shabhi
that
and Monica,
day, yeah, sorry.
everyone. Yeah. Thank you so much, Dr. Jasmine.
Yeah, and
It was
anyway,
wonderful
if
listening to
any
you.
one of you are FICOGs in this group, so please do vote and support me for ICOG Vice Chairperson elect. Only the FICOGs and MICOGs can vote for those elections.
Okay, Dr. Shabhi.
Thank you, ma'am.
Is all yours. Yeah.
Thank you, Maninder ma'am. Thank
Yes.
you once again, Anita ma'am. So good to see you all. We will move on to the next session. Very nice talk by Dr. Jasmine. Our next session is a very interesting panel discussion. Again, a very common topic for all of us. The discussion is on optimizing treatment outcomes. Dr. Jyoti Malik ma'am and Dr. Niharika Tyagi ma'am. And our expert for the section is Dr. Shweta Mittal ma'am. Slides, please. Yeah, Dr. Jyoti Malik ma'am, Institute at JIMS. She is the chairperson of the Haryana chapter of ISAR, as well as the secretary of the Haryana Association of Registered Obs and Gynecologists. She has very, very many achievements to her credit and has various publications both in international. Yes, thank you, ma'am. Welcome, ma'am. Yes, ma'am. Our next panelist is Dr. Niharika Tyagi, ma'am. Ma'am is a consultant infertility and fetal medicine specialist with fellowships in fetal medicine, critical care, obstetrics, prenatal genetics, as well as fetal surgery. Yeah, welcome, Niharika, ma'am. Our expert for the session is Dr. Shweta Mittal, ma'am. Dr. Shweta Mittal, ma'am, is a Secretary General of the Indian Fertility Society, as well as has been the treasurer as well as of the AOGD and the convener of Reproductive Endocrinology Society, IFS. She is a recipient of various awards. Welcome, Shweta, ma'am. We have a very interesting group of panelists for the day. We have 8 of them. Our first panelist for the session is Dr. Manisha Bhagat, ma'am. Dr. Manisha Bhagat is a consultant fertility specialist at Indira IVF at Jammu. She is a center head and the chief consultant over there since the past 4 years. She is also a consultant at Jammu and Kashmir Health Services. Welcome, ma'am. Our next panelist is Dr. Rajni Jindal, ma'am. Ma'am is the director at Jindal Heart Institute and Infertility Center at Bathinda. Ma'am has over 20 years of experience in clinical practice, and she has been the pioneer in IVF, ICSI, and PGT fertility preservation and gynae endoscopy in and around the areas of Punjab. Welcome, ma'am. Our next panelist is Dr. Rakhi Malhotra, ma'am. Ma'am is the director of AAS Fertility and Maternity Center at Rohtak, Haryana. She has a special training in IVF as well as in laparoscopy and hysteroscopy, and is the vice chairperson of the Haryana chapter of ISAR. Welcome, ma'am. Our next panelist is Dr. Rakshita Malik. She is the center head of Indira IVF at Hisar, as well as the chief IVF specialist. She has done her fellowship as well as currently the center head and senior consultant at Hisar. Welcome, Dr. Rakshita. Our next panelist is Dr. Neeru Thakral, ma'am. Ma'am is the director of Thakral Hospital and Fertility Center. She has a fellowship in reproductive endocrinology from Germany as well as a diploma in endoscopy. Ma'am has a special interest in ART, reproductive endocrinology and endoscopic surgeries. Welcome, ma'am. Our next panelist is Dr. Seema Mittal, ma'am. Ma'am is the director of Lalita Memorial Hospital since 1998. That was the first IVF center in Haryana. She has been the past president of Rewari FOGSI Society as well as the secretary of Haryana chapter of the Indian Fertility Society. Welcome, ma'am. Our next panelist is Dr. Manisha Jain. Dr. Manisha Jain is a senior consultant and IVF specialist and my colleague at Nova IVF Chandigarh. Dr. Manisha has presented various papers in various regional, national and international conferences, as well as the executive member of Chandigarh FOGSI Society. Welcome, Dr. Manisha. And we have the very young, last but not the least, Dr. Vandana Mohan. Dr. Vandana is a consultant at Nova South End Fertility and IVF Center at New Delhi. She has a diploma in clinical ART and is a member of various organizations. Welcome, Dr. Vandana. Over to you, Dr. Niharika. Discussion.
Yeah, thank you so much. Thank you, Dr. Shatabdi, for introducing our panelists. And we have people from Haryana, from Punjab, from Chandigarh, and from Delhi. So can I now share my screen? Okay. So with my co-moderator, very beautiful Dr. Niharika Tyagi, we would be taking you through with our expert, Dr. Shweta Mittal, and with all the panelists. Panelists have already been introduced. Dr. Niharika, should I start so we can then alternately?
Yes, ma'am, that would be better. Yes, ma'am.
Yeah. So this is, it is a very, as we all have been doing it, IUIs, and a very basic topic, but still we keep on discussing it so that, I mean, because we want to improve our pregnancy rates, though IUI sometimes is so frustrating, we don't get results. So how to optimize our result is something we wish to discuss today. And this is a very common case scenario where a 32-year-old couple, they come to us, they have been trying to conceive for the last 2 years. Everything is normal. So man has normal semen parameters, woman has a normal examination, hormonal tests, and a pelvic ultrasounds. So what would, should we be doing a IUI for her? I mean, what should be our advice to them? And before doing the IUI, would we always do a tubal patency test as a before trying to start their treatment? So anyhow, I mean, anybody can start with it. Dr. Manisha and Dr. Rajni, I did not see, I think. I could not see them, but I think we can start with then Dr. Rakhi or Dr.
Yes, thank you, Dr. Jyoti and the whole organizing team for giving me this opportunity. Am I audible?
Yes, yes.
Hello?
Yes, you're
okay.
audible.
I think HSG is mandatory. We need to we need to know whether tubes are open or not. Otherwise, we cannot go forward for the IUA. So this is a mandatory test which we need before IUA. And second, semen parameters, you say that they're normal. And patient has been going infertility treatment for how long, Dr. Jyoti? May I know, please, again? 3 years?
2 years.
4 years. So I think this is the right time when we should go forward for
only 2
go
years.
forward. Only 2 years.
Yeah.
If the patient has been simply trying the normal relationships for last 2 years, then we can avoid the IUA. But if she has taken the ovulation-inducing drugs only and the rupture and documentation of the dominant follicle has been established by the sonography, then we should go for the IUA if she has not conceived with the normal ovulation-inducing drugs.
Okay. So suppose, she has not tried any ovulation induction and all as of now. They are just trying now. And now since they could not conceive, so they come to you. So would you, that is my question, that whether IUI versus a normal intercourse, what would you advise to them? What does the evidence tell us about are IUIs worthwhile? Should we straight away, what
See,
would
evidence says that IUI always is better than gives the more pregnancy rates than the normal relationships. But if the patient is going for ovulation control ovulation stimulation, then only IUI are more successful as per the evidence. So with IUI, we have to give the advise the patient for the controlled ovulation stimulation with IUI. But if the patient is not taking the control over stimulation, then simple IUI does not work that much. That's what I want to say.
Okay, yeah, right. So there is IUI versus intercourse. There was in unstimulated cycle actually. What this RCT said that pregnancy rate was only 4% compared to 2.4% when we allow them a timed intercourse. And this was, so they say there is little evidence to assess IUI in unstimulated cycle. So doing a IUI in a stimulated cycle is something which would be better rather than going for an unstimulated cycle. Now, we had this paper here, and these are the various RCTs actually that I took out. And these RCTs are from these latest ESHRE guidelines. And what does they say? They clomiphene compared to a timed intercourse. So this RCT with her 385 women compared 6 months of expectant management with clomiphene with only expectant management compared to clomiphene and timed intercourse. And the cumulative birth rate was 16% actually with expectant compared to 13% with the CC and timed intercourse. Then letrozole with timed intercourse compared to expectant management, there were no relevant studies. Gonadotrophins with timed intercourse versus expectant management. Again, there were no studies that could be identified comparing stimulation OS with gonadotrophins and timed intercourse with expectant management. So this again timed intercourse versus IUI in a natural cycle. Now compared to CC with timed intercourse, treatment with IUI resulted in a little higher birth rate as Dr. Rakhi suggested to us. And so with CC, it was a little better. Now, timed intercourse versus ovarian stimulation and IUI. So this RCT that we normally, most of us follow, that always we do a ovarian stimulation and a IUI. It is not just unstimulated IUI. Normally, most of us do not follow. So in this RCT, they said that couples were randomized to either receive CC and timed intercourse or CC and IUI. And they say that the conception rate were not statistically different between the timed intercourse and IUI. Though here they are saying 41% and 18%. So I don't know where is the problem, because this is a quite significant difference between the time these two results. So according to this, I could not understand why they are saying that it is not statistically different, but they are showing that it is nearly twice. With the IUI, the rates are 40%, and with only a timed intercourse, it is only 18%. So the recommendation with this guidelines of 2023, they say that IUI with stimulation is the first line treatment for couples with unexplained infertility. And the G guidelines, they advise to base the decision to start active treatment on prognosis in couples with unexplained infertility. Now, there's a Honnold model as well. Anybody has heard about it, or anybody can comment about it? Because there is something based on that we can like categorize the patient, whether we should give them time or whether we should give them go for a active treatment. So anybody can say mention anything about Honnold model? Otherwise, maybe we can go further.
May I?
Honnold model. It is, yeah.
Ma'am, yeah. Ma'am, it's just a model to predict the chances of conception, pregnancy. So there are various factors, especially the age of the women, whether it's a primary or the secondary, the duration of the infertility, then what is a BMI. In the modified version, there is also the BMI, the FSH levels, and what is the sperm parameters. So there are various factors which predicts what is the chance of pregnancy in the next 12 months.
Yeah.
So if there is more than 30, less than 30%, and then we can guide them whether to wait or to go ahead with the treatment.
Yeah, actually, according to the age, duration of pregnancy, what are the previous treatment that they have taken, the previous pregnancy, whether it has occurred or not. So based on that, this model was created, and according to this, like one can sort of wait, maybe give some expectant management, or give a active treatment, like maybe do stimulation and IUI. So based on that, but the limitation was that it was only for the Canadian studies and the Dutch population, and it was only used at the time, at the first instance only, at the first visit, and it was not for the follow-up. So, but such models can at least guide us whether we should ask the patient to go in for IUI, because sometimes even the patient does not like to go even for IUI. They say we want to try naturally. In spite of IUI being a natural process, still sometimes it becomes difficult to convince them to even go start doing IUI. So
the Herald model actually, despite of the fact that it has given a lot of things inside, they are very basic things they have included. Like they would say PCO people have good chances of conception. We all know, yes, PCO people will conceive someday. Then a few, just very illogical things also they have included, like cervical factors. If there is a cervical factor, then IUI, we all know over time, that is why PCT had gone out of vogue, that cervical factors are nothing actually. Now nobody does PCT just to rule out cervical factors or like that. I come from an era like way back in 2010 and 12 when we used to do PCT.
Yeah. And so now we don't, our new generation doesn't even know how to do a PCT.
A very interesting thing that we can do ever since, like, we are just 12, 13 people of us, like when we treat vaginismus patients, they many times come to us telling lies about it, that yes, we have been able to, have a relation, but we are still not able to conceive. They just want you to do an IUI so that they are not pushed for relationship. So in such patients, if they allow you a PS examination, doing a PCT post-intercourse tells you that whether they had an effective intercourse or not. So that's the only place left for PCT in today's world, to be honest.
Yeah.
So that is all Herald has included. So probably, but yes, never mind. Still a thing to teach the new people who come to.
Yeah. So one can sort of at least how fast we should move for that patient. Maybe it can give us a little idea. And as you were talking about vaginismus, in fact, I had a patient who, for the last 1 year, she was married and they could not have proper intercourse. And she came for a IUI, and now with the IUI, she's carrying twins and she's around 28 weeks. So there are cases where such sort of situations where we can do that. But otherwise, I think it is PCT is out of place.
Jyoti, can I?
Yes, ma'am.
Can I?
Yeah.
I wanted to share a very interesting case with you. I had a patient about, I think, 25, 30 years back. She was a case of vaginismus. And she came to me pregnant. And she would not allow PV. And when I did the ultrasound, she was already 13, 14 weeks pregnant. So I asked her, she says, I never had intercourse. So how did you get pregnant? I knew that she used to write a diary because she was a lawyer and she was a Supreme Court lawyer. And she had gone to UK also. So I asked her, did you do coitus interruptus? She said yes. She had done the coitus interruptus, and by doing the coitus interruptus, she got the pregnant. So this case I never forget. And she said, my Guruji had advised me not to go for intercourse. So, but you now had to become pregnant. So with coitus interruptus only, she became pregnant. So
they do self-insemination. Such people, they just feel that I cannot do it. They do self-insemination of semen also.
Yeah, sometimes they are doing anything, but even she did not know that she had become pregnant because she would never allow PV examination. With very difficulty, I'll do the TVS. Very difficulty. So anyway, so these are the rare cases.
Very, very rare cases, yeah.
Yeah.
So, Anisha, which are the situations where you, what are the indications actually of IUI to start with?
Mostly the best cases for IUI, I feel, are anovulatory PCOS. There you do ovulation induction with at times just simple agents like letrozole, and once the ovulation is induced and they get pregnant. One is that. Second, of course, we do IUI donor cycles. When the azoospermia is there, then donor semen insemination, male factor infertility, whether azoospermia or just mild oligoasthenospermia. And in cases where there have been a little endometriosis, mild endometriosis kind of people who eventually have just subtle subovulation kind of a thing, in which when you induce ovulation and you give her a better trigger, they ovulate and then the IUI is successful. But generally I've seen in these mild ovulation induction case, mild endometriosis cases where there have been long unexplained infertility, they generally don't conceive. Generally don't, but yes, at least if there's a short married life, you have to offer them IUI, at least prepare their mind and give them that 12-15% of success rate. These are the only few cases.
And Dr. Seema, if you're there, what are the absolute contraindications where we do not do a IUI?
See, one thing is that PCOD doesn't make an indication for IUI, as Dr. Nisha has mentioned. That's what normally we don't do. And absolute contraindications, as such, there are no absolute contraindications for IUI. But if it's a tubal blockage or it's azoospermia, where we are not going for donors. So other than tubal obstruction, or it is a endometriosis, which is grade 4. All are relative contraindications, not absolute. So for me, absolute contraindications are if it's a tubal blockage or if it's a severe endometriosis.
Or the semen count is very less. It is not fulfilling the criteria for IUI.
Yeah, severe oats, we can say. Severe
Yes.
oligoasthenospermia.
Yeah.
Right.
So, Dr. Niharika, Dr.
I just wanted to add.
Yeah.
I just wanted to
Dr.
add that IUI is also helpful in patients where when we advise them time intercourse and under the pressure, they are not able to have that time intercourse sometimes. So there in that patient's IUI is very helpful.
Yeah.
And then these days there are couples like they are in Navy merchant and they're flying a lot of time and they have been trying and they want to freeze their sample and do the IUI when the husband is not there.
Yeah.
Very right.
Yeah.
But that's not, you're asking about the contraindications.
And also army, many patients come where my husband is in army and he has come only for 2 months vacations, and for whole year he will not be there. Many patients come nowadays. So in that case also we do the IUI and ask also them to make the relationship after that.
Yeah, cryo-freeze sample.
Right. So now we come on to the second case, Dr. Niharika.
Yeah.
Thank you, Dr. Jyoti. Now we go down to the second case. Now she's a 28 years old. She's trying to conceive for 3 years. She's PCOS by her scans. Her BMI is 26. Her semen analysis and tubes are normal. Her tubes are patent. She's been trying ovulation induction by clomiphene as well as letroz and more, and had several cycles. Now she has come for an IUI. Now, let's discuss how would we go around this case. First of all, are there any health intervention that you would like to discuss with her or the couple at this stage? If so, then would you elaborate? Dr. Neeru, if you would like to take this question.
What is her BMI actually?
Her BMI is 26.
26.
Yeah.
So yeah, I'll tell her to reduce the weight. Even 5% reduce the weight definitely help.
Okay. Anything else that you would want other than weight reduction or something?
I will check the sugar level.
Yeah, I guess
blood
that's also
sugar.
a good
That is
option.
very, very important. Many
Yeah.
patients, they come, their HbA1c is 7, 7.8. They
Right.
conceive and then they abort. So definitely I have to control the sugar level, check the HbA1 level, HbA1c level. Then only I'll start ovulation induction. And my only drug, monofolliculars, for molecular purpose, I use letrozole in these PCOS patients. If
Okay.
I have to use oral ovulation.
Okay, so for when we talk about health intervention, we should not just think about decreasing of weight gain. I think psychological factors also take a lot of role. Anything you would like to add for psychological? So psychological, if she wants a diet and a good activity, that should be explained to her that how she should go around. And yes, definitely, like you said, not just the sugars, but also her blood pressure. That's very important. Now we come down to the next question. What are the practical tips that you give for a woman regarding the lifestyle? Just saying that weight reduction, अभी हम ही लोग 3 किलो वजन कम करने की कोशिश कर रहे हैं, हमारे लिए इतना मुश्किल हो रहा है. So when you talk about such kind of people who want a desperate weight reduction for their health issues as well as fertility, what are the basic tips, practical tips that will actually going to benefit her and she can follow those tips? Dr. Manisha, Dr. Rakhi, anyone?
Yes.
Mm.
Yes, Dr. Rakhi, are you taking this, please?
Yes, yes. Yeah, basically, we need to tell her about lifestyle modification. We need to tell her about the importance of the exercise, daily exercise of 20 to 30 minutes. We ask her to go away from the junk foods and make the protein diets and normal weight reduction advice which we give to every patient, and plus the meditation for the mental health, and with diet reduction I will specify more on the physical activity and exercise basically.
See, walking 10,000 steps. 10,000 steps a day is ideal for them, that they can do 5 days in a week. And it's basically about being very active, not necessarily reducing weight. So they can just go for physical exercise, not focusing on weight initially, just to be active, and then gradually it settles. The diet schedule is also very important. How we say 6 divided meals, 2 hourly meals, which is fat-free, sugar-free, and not like starving or fasting. That is really, really bad for them.
I generally also ask them.
Dr. Jyoti has very well given us this very nice slide, and a very first point that she has put on is the SMART measures, the specific, measurable, achievable, and realistic and timely. So that is the most important crux of any lifestyle modification, any lifestyle advice that we give. It should be very specific, like you said, at least 10,000 steps she should do. Measurable, at least she could measure it that she is taking this much of calories, that should be advised to her. She should be made sensitized that how to calculate her calories, what are the actual calorie according to her BMI, her height, and how much she should take. And whether it is achievable just by saying 3 kg weight in 1 month, it is not, it is not, it is actually very cruel for her to say that you do it. Why haven't you come with a weight loss when she comes to you for her next period? So you should be very, very, very gentle, and we should understand it is very difficult and completely realistic and have a proper time. So if taken a help of a nutritionist, that would be the best in such cases, and just avoiding simple refined sugars and junk food is very difficult for us also to avoid ourselves from taking it for 30 days. So we can ask her to have 1 day cheat meal out of 6 days. So something very realistic where she can follow it and gradually come down to a better plan. Also,
Actually,
yes, please do.
Actually, there are apps, many
Yes,
pharma companies. So we put it in the OPD.
Very
We
nice.
ask them to scan them, and then you can daily go through that. What are the diet and how much exercise,
Right,
what type of
right,
exercise you have to.
right. And lot of apps available even to tell you what to do, how much exercise to
Hmm.
do, what exercise to follow, and what is the achievable target which is healthy for her. So the next
Right.
question become, what metabolic parameters are of interest for fertility enhancement?
See, this is serum fasting insulin. We would like to see that it is less than 10, and her lipid profile and her blood sugar levels.
So
And
what are
then
the parameters that you see other than the fasting one? Are there any other fasting other than that fasting glucose that you see and insulin?
Do you see
P-
profile?
PCOD profile,
Right,
full PCOD profile,
right.
endocrine, FSH, LH, serum prolactin, PSA, DHES, fasting insulin,
So
OGTT.
so do
that
you
is
do
what
DHES?
okay.
So
Patient is
basically,
not
that
pursued. You don't need to do
metabolic
it.
things we
Yes, she's not
also have to
Hershey's
see a
as
lot.
such.
I
Not to
think
do DHEA or 17 OHP if she's
even
not.
even in adolescents, they say that you have to do a lipid profile for them every year.
Yeah,
Right.
Adolescents also. So
yeah.
right that time we have to start seeing and rule out all the rule out all and see her as a complete human being, like not only her weight that we should be focusing on, we have to focus
True.
also on her metabolic parameters, her sugars, BP, lipids, reducing her cholesterol, see where able to have a, because some of these obese women have a lot of sleep apnea, and
Right.
that also should be ruled out. They should consult a sleep therapist and find out, or maybe get a sleep this thing test. I don't know what we call it, but you can put in those the sleep study. I think we call it sleep
Sleep
study.
study.
Yeah.
Let's see your snoring and everything. How many
Right.
times you wake up, your REM cycle and everything they see.
It is very severe. Sometimes you might even have to use a CPAP or something like that.
Yes.
And
Many of them are already using.
even we have to focus on their mental health, on their body image, their rule out. I mean, they have always to be like Dr. Sabharwal was telling. They had a psychiatrist also. They had a physiotherapist, a yoga teacher, and a endocrinologist in their panel, the one she had just attended. So, I mean, we have to be take her as a multidisciplinary approach, and we should give her an optimal time frame. And what is that time frame you feel, Dr. Seema? How much time would you give this lady with a BMI of 26 so that she becomes optimum? And if she achieves it, how long would you wait? Would you wait for a spontaneous conception, or would you like to treat her?
See, that will depend on her age. If she's a young patient, we give her time. 6 months is the ideal time.
28, trying for 3 years.
She's 28 years. For her, in her case, as a practical approach, we go for diagnostic lapro. And like your next question, that just puncturing and just doing that LOD helps her. And we go straight away for investigation, because if you go with the evidence, we have to tell her lifestyle modification, give all stimulation drugs, and wait for 6 months. If she doesn't conceive, then we have to go for laparoscopic drilling. But in our setup, she's already 28 years. She is 3 years. She's trying, and just putting in a laparoscope, managing her ovaries, that really helps. And we don't really require any IUI, even if the sperm count is low. So my approach to this patient will be simply have a look, just find out if there is any endometriosis starting early, or in our setup sometimes they have some fluid in POD, which I send for tubercular examination. And 7 out of 10, if this is the picture, they conceive automatically without any suffix or prefix, just without any treatment. So for this patient, my management simple will be diagnostic laparoscopy followed by drilling if required. So
No, I think drilling, we haven't done the LH levels. If the LH levels are more than
normal.
10, then
Let's let normal. Take it normal. Everything normal.
no, then PCOD drilling will not help. PCOD helps only when LH levels are more than 10. Ovary is bulky.
That
In
is
that case,
why evidence agreed. Let literature says everything says, but if I go with my
and simple ovulation induction can also help in this patient. And we can wait. She's 28-year-old and all her hormonal parameters are normal. Simple with controlled ovarian stimulation followed by IUI can help us. We don't need for PCOD drilling. I think
6 months, 6 months, we are saying that is the time period for her to
Coming
manage.
something so early, we'll keep at the last option. If we are doing a laparoscopy, we are not coming to LOD drill.
Yeah. So otherwise, 6 months is the time period that we will give her for
So
managing
now,
all her
now
things.
she has lost weight. Her periods have started coming because previously she had amenorrhea, but now at least her periods are irregular but spontaneous. Previously she had to take withdrawal. Now at least the good thing that has happened is that now she's getting spontaneous periods. It is more than 6 months now. Her AMH is 5.1. And now would you prescribe her, what all would you prescribe her? Non-ovulogens or adjuvants would you start? And if yes, what all? Anybody? Would you start with her on metformin or that MCI, DCI, some adjuvants? Would you start her on any? Or
yes. We will start when we are giving her the 6-month period. I think at that time only we should start the metformin before going for the ovulation-inducing stimulation. That affects a lot because metformin side by side when we start the ovulation-inducing drugs, that might not affect much. So in that waiting period, 6 months, when we are asking her to reduce the weight, and at that time also we can advise this lady for the adjuvants and followed by then control with stimulation with IUI.
Especially in obese PCOS, now this oral adjuvant will definitely help to lose weight also.
So, Dr. Nero, what fertility options would you now start with her? Would you talk of oral agents? Would you think of gonadotrophins with IUI? And as Dr. Seema was now also planning a LOD. So, what all would you discuss with this lady? I mean, how would you go about in this girl?
Yeah, as discussed earlier, my first step will be the oral ovulagen. So oral ovulagen, I will be choosing the letrozole only. So I'll start with the letrozole because I want a monofollicular. If the patient doesn't conceive after 2 cycles, if there is any letrozole or clomiphene failure or resistance, then I'll give her the option for gonadotropins. Gonadotropin also, because she's a PCOS patient, I will use low dose step-up protocol. I start with the very low dose. But yes, tell the patient there are chances of multiple pregnancy. That always I tell them in gonadotropin, there can be multiple pregnancy, and tell them we have to take longer time. Sometimes patient will take even 20 days with the step-up protocol so that they at least have patience. Many times eggs will be formed after 15 days, after 20 days, and then they stop the treatment. We get a good result with the injections, also with the gonadotropin. Yes, if the patient is far away, cannot come for the follow, very lean and thin, LH is very high. In those cases, I may go for the drilling also. Patient is from very far places, cannot come for follow. Then we don't want to take the risk of OHSS. Then I can go for ovarian drilling also. But many patients can say with the oral ovulagen, sometimes we have to take the injectable. Sometimes she's endometriosis or other causes. We are doing the laparoscopy, septum, anything along with this, polyp is there. So we can do drilling also.
So
I
I
doesn't
think
conceive
drilling should be
anything.
the last option when we talk about somebody who's going for a
Especially
fertility.
patient is from far
Yes,
away.
And
yes.
she's
This is the
so
last
diligent on
option.
doing weight loss also and has a spontaneous, no hirsutism, spontaneous cycle she has come out. So ovarian drilling is definitely, at least in not this case, we very rightly said, need not be required, at least right now.
Yeah.
Yeah. So Dr. Nero has told us which all particular cases only need LOD, a lean thin, a previous OHSS, or a patient who does not want to go in for gonadotrophins, who's from far off, who cannot come for repeated scans, and there is no difference. About the LOD, there's no difference in the live birth rate over 6 months, and no difference in the spontaneous abortions. And in fact, the multiple pregnancies are significantly lower compared to the gonadotrophins, but there is a operative morbidity, there's a risk of adhesions, and if not done properly, there is always a risk of losing your AMH levels and the ovarian reserve. Now, yeah, Dr. Niharika, your patient now, and this is the situation of, you can read it out. Dr. Niharika? Okay.
Yeah, hi. Now, now when we see that she has come for an IUI stimulation started, and we see that on that second day, and you give it for 5 days, you are giving her letrozole, and followed by your HMG injection, and you see your AFC to be around 20 and 18 mm. Eventually, AFCs are a total 20 and 18 in both the ovaries, and after your HMGs, you get a follicle around 14 and 13 two follicles, or approximately on each side. You got an endometrial thickness of about 7.5. Now, we have another. So, how would you like to proceed in this case, and proceed for an IUI, or you need to add some adjuvants for this? Or would you like to cancel this cycle and act for an abstinence for intercourse, or you would convert this for an IVF? So we have all three options. Which would you prefer?
This patient might go for OHSS if we give more injections. I think this is the right time to add the antagonist here and now, and we should trigger with agonist, not with the routine HCG injections. Trigger should be given with that, and serum estradiol will help us at this time if we do the serum estradiol, whether it is more than 1500 or not, so that we should not land up in the OHS, because they're very small follicles. 12 follicles are 12 millimeter follicles, and 14 2 and 2. So this time, if the estradiol levels are more high, we can even not give we can stop the procedure also if the estradiol levels are more high, so that patient doesn't go for OHSS. But if it is less than 1500, then we can go for the lupus agonist trigger, and then we go for the IUI.
Dr. Manisha, you would like to differ from Dr. Raki. She wants to add antagonist to this and proceed for a IUI. Dr. Raki wants to go ahead.
If estradiol levels are less, than 1500, then only I will go for the trigger and for IUI.
Okay. Dr. Manisha, what would you like to do? Please unmute yourself. Unmute.
So I wouldn't like to go for an IUI in this situation. Actually, she has a high risk of OHS, but definitely I can still give a try after calling her after 3 to 4 days. So at times, just dominance comes just in 2 follicles, rest all regress, though less commonly, but still give her an actual chance and call her after 3 days. You may have dominant follicles, 1 or 2 in each ovary, and rest all just go arrest at 12-14 stage, maybe.
So there are only 2 follicles that are 14 mm in right and in left. Yeah.
Yes. So you can call her after 3 days. If the dominance happens only in 2 or 3 follicles, you can go ahead with an IUI.
Many times it happens. We stop the drugs, call after 2 days, and we have hardly 2-3 follicles.
2-3 follicles. And because at that stage also it has reached a thing that you have it, because the cutoff is 3 follicles for IUI. For me, I take 3, max 4 follicles for an IUI.
Right.
Right. So after 3 days, if I feel no, all 3-4 are dominant, I would rather ask her to go for an abstinence and come in next cycle. She won't lose much. She's just 28. We can definitely try, and she'll be convinced about herself that if it happens again, you will be able to convert her into IVF in a better way.
Dr. Neeru, would you like to, Dr. Seema or Dr. Neeru, would you like to cancel, or somebody would like to take her to a IVF, convert it to a IVF cycle?
She had only 5 follicles, so I would not like to take to IVF. Definitely, nicely told by Manisha that we don't give gonadotropin call after 3 days. Many times we have hardly 2 or 3. And if we have 5 follicle, even if my E2 is less than 1000, but 1200, I would not like to give agonist trigger because multiple pregnancy chances are still there. So if it's more than 3, I would never like to go for IUI.
So what our guidelines suggest is that to prevent high rate of multiple gestations in IUI-OS, IUI should be withheld when we have more than 2 dominant follicles, more than 15, or more than 5 follicles, more than 10 at the time of HCG or when LH surge is present. And if you have used gonadotrophins in IUI, 75 or lower should be used because higher doses will give similar pregnancy but would increase the multiple pregnancy. So when more than 2 dominant follicle, more than 15, I think they ask us to withhold IUI, and more than 5 follicles, more than 10 at the time of HCG. So then another good practice point that they have suggested is that as an alternative to cycle cancellation, one can aspirate the excess follicles at the time of HCG, and so that this could reduce the risk of multiple pregnancies. Now, this case, I think we had cancelled this cycle. So this lady again comes. That we did not go ahead with that. The IUI last time. And this is another cycle where only the letrozole is being given and there is no gonadotrophin being added, seeing her past record. And IUI was planned because she had only these 2 follicles. One was 18 and one was 16. So on the day of IUI, the husband could not give us the semen sample. He failed to produce semen. So could this situation be avoided, and at that time, what all can be done? So anybody can take it.
Mostly, if counseling works quite well, and avoided, no. Mostly, the only thing that you know about is never go for an IUI cycle till you have 1 semen sample in your premises during the time of stimulation, at the start of stimulation, prior to that, so that you get to know about the ejaculatory issues. So much so that at our center we have included in the package that patient is not to pay for the semen sample, because payment parts, they generally feel, why should I give one? I have already have 5 reports, I have 10 reports, ma'am. Like, so we say, no, this is free of cost. This is our mandatory thing. You come, you give the sample. We won't cost you for the same. Then you know about the ejaculatory issues. I think that's the only thing that can be avoided. Secondly is the ambient environment of your semen collection room. At times, like we have do not knock thing, magnetic do not knock thing, and whenever some husband is inside, that is pasted outside the door so that nobody knocks inadvertently just to use the washroom or maybe like that. We dedicated semen collection room with an attached bathroom which has a good ambience and maybe like relaxed attitude. Wife can be allowed. That is one thing. Now coming to the tackling the situation again, wife can be allowed. Counseling works very well. You can give, after checking the parameters like blood pressure and other history, hypertensive history, you can give sildenafil or tadalafil. I generally give 50 mg sildenafil, and at times in obese males you have to give the higher dose as well. But generally 50 mg works well, or 5 mg of tadalafil. So most of the patients are able to give the sample with this, and home collection at times.
And the vibrator also. 1 night prior.
Vibrator also given to some patients.
Sildenafil works in 3-4 hours, but tadalafil needs longer time. So we have to give, it's a good drug, but we have to give 1 night prior.
Generally, I give sildenafil only because any day we have it in our
available,
because of the
we all have, yes,
giving them for IVF patients for thin endometrium. So I generally give sildenafil. I don't have much of tadalafil thing.
Tadalafil we have to give for longer time. If they have many months, she has a strongest ejaculatory problem, we can give that for the longer time. For shorter duration, we always give.
Also, tadalafil is available in a strip also. They just put it beneath the tongue and it is very effective.
But
I haven't
effect comes late.
I haven't used it, so I have to check with some urologists. I haven't used it ever.
I think this now the sample was provided and the report read as below. So there was the sperm concentration was 10, motility was 20%, and morphology was 3%. So what next? Would you go ahead with IUI? Would you do a donor sperm? Would you cancel the IUI? Give them antioxidants, again review, do a detailed evaluation later on, or advise them IVF FOGSI? How do you proceed now?
This
Better
report
to
after
go from
washing or before wash?
from washing and see the sample. What is the result?
Yeah.
So after wash also the motile sperm count was only 30% and morphology was 3%.
You can go ahead with IUI, no problem in this patient.
Double collection can be done on the same day, and this cycle at least you have already done everything. So this cycle you must go ahead, and then
Morphology is good enough.
Yeah.
and double
I
collection.
think morphology is less than 4%. So we need the detailed evaluation for the further management. This time, since sample is prepared, we can insert it, no problem. But since morphology is not filling the criteria of 4%, so I think detailed evaluation is necessary.
Yeah, so all the panelists are right because they say that you can go ahead with IUI at this particular sample as well, because it is not possible to define clear lower cutoff levels of a pre or post wash sperm parameters below which IUI should be withheld. So it is not that there are no clear lower cutoff margins, and with the post wash total motile fraction, obviously higher pregnancy rate are there when the total motile fraction is in the range of 10 to 20 million. And if it is lesser than that, if it is in the range of 5 to 10 million, the pregnancy rates are much lesser, around 5%. And if it is less than 5 million, it is still less, it is around 2 to 3%. So,
Right.
which particular, Dr. Niharika, are you there? So,
Madam, I'm there.
yeah,
So, which semen preparation technique would you prefer, and how would you say that this technique is much better in terms of pregnancy rate in IUI? Anyone? Dr. Rakhi?
Ma'am, if the good motile sperms are there, then we can do the semen wash, simple semen wash for the extraction of the sperms. But if there are more debris and the sperm count is less, and then we should go for the swim down technique in IUI. But mostly in IVF, we go for the double density gradient only as a standard technique to gather the sperms from the semen
So
sample.
the house agrees to use a
Double density.
double density gradient in such cases.
Yes, yes.
Yes, usually the double density is the best one we all use. But yes, when the count is very good and the motility is very high, then yes, we can give the option of swim up technique also.
Yes, definitely.
And when the count is very less, then even a simple wash is used for an IUI sample.
Right.
Yeah, so there's no difference. There's no evidence of a difference between the pregnancy rate for swim up versus a gradient or wash and centrifugation. So there's insufficient to recommend any specific preparation technique. One can use anything. So though we are commonly using the density gradients and all, but according to this guidelines, they say that if the sample reaches in 30 minutes in a non-toxic container, there is no difference in the method of semen preparation. They do not have any profound effect on the success rates. And though it in this particular gradient technique that there was a prospective randomized study where they suggested that there was a higher ongoing pregnancy rate per patient after gradient technique compared to the swim up of nearly doubling 20% versus 10%. And this was actually, this difference was significant only in couples with unexplained infertility. So there they have suggested a gradient technique, but otherwise they say according to the available evidence, it is not possible to recommend any semen preparation technique over another, be it swim up, gradient, wash, and centrifugation. So Dr. Niharika, over to you.
Now when you're doing your IUI, you face a difficult situation that you cannot negotiate your catheter. What will be your approach in such type of cases where you have a difficult insemination because of a catheter issue? What are your choice when you come for your catheter, a firm or a soft one? Are there any other techniques that you can do when you are not able to do a conventional IUI or cannot negotiate your catheter? Dr. Seema?
See, best is the situation should not come because pre-assessment of every patient that you are taking for any procedure, like upper speculum examination, PV examination, and if possible, like for IVF, we do trial transfer for all patients. So for IUI also. But then
Yeah.
soft catheter, if soft catheter is not being negotiated, then we have to do ultrasound guided IUI where we can use a little hard catheter, but it has to be ultrasound guided. And at times we do attempt dilatation with the dilator also, which is actually not good, but that really helps. So we have to make sure uterus is retroverted or antiverted, and there is no thickness in the fornices. And then we can take help certain drugs like meso and all also at times help. So they can cause some bleeding and we might need to postpone that cycle. But if it is non-negotiable service, then we have to go to the next cycle. And before that, we have to do good dilatation with meso or under anesthesia also at times. So if we are pre-assessed doing the treatment, these problems usually don't happen.
Yeah, so we can at least start with doing the basic, like seeing if the bladder is full or not, at least doing a knee chest position that we can use a Sims or a tenaculum instead of a Cusco, readjust the Cusco, see your size of the Cusco, whether it is good for the vagina or not. And definitely doing an ultrasound guided now that the IUI room and the USG room are nearby. So at least an ultrasound guided can be done very, very, very conveniently.
The
And
best
because,
actually, yeah.
yes, yes, yes. Anyone else would like to add on at least on that?
Not possible in this cycle, at least just do a foot end elevation and do intracervical insemination. Anyway, at times it
Yeah,
really
rather than
gives you
cancelling,
the
yeah, that
capillary
makes
action, like we used to do HSGs in our intern time. So even if you're not able to, negotiate it properly, ribbons say when we used to do, so we used to put it there, and at times just because of the capillary action, it used to fill the cavity. So that thing you can at
But
least.
watch samples, intracervical and intravaginal, they really don't help because the sperm
But it
concentration
is
becomes.
a better option than just cancelling it. Already
Yeah,
you have
I
a
think we
semen
all are
ready.
doing that actually.
Yeah.
Yes.
What each panelist can add, what all they tried, any particular case, anything new they can add to in a difficult IUI, any more things apart from what Dr. Niharika has summarized.
See,
Any-
laminaria tent was one thing. I used to have laminaria tent when we were postgraduate. We were using for pregnancy, like stimulation. We didn't have meso. So we used to put laminaria tent. And I had in my hospital also. And we were trying that. That was really helpful. But now neither I'm getting it. No, it's like we've not tried. But that was really, really helpful in cervical dilatation, in all difficult cases.
So I had a very interesting case. We saw her 6 months back, planned her for IUI, but she did not come up. And it was almost next year she came. And because we have a lot of residents who are doing the stimulation part, so she went for the IUI and we cannot negotiate. So what we did, we call her to the ultrasound room, got the bladder filled, did a Sims Ellis. And then when we did the scan, actually we found out that it was a broad ligament fibroid which was pressing the cervix and it was deviating the cervix. So even though we had negotiated it, and then we had to actually operate her for the next month and then do an IUI after that. So it took us 3 months. So definitely with a scan, I think nothing better than a scan can help us in such situations.
Dr. Niharika, no scan was done for her before because IUI we do only after
No,
looking at
definitely IUI is being done, but basically when you look into the IUI time, it is a broad ligament fibroid is some kind of a fibroid that is a cervical fibroid that might have been missed by the person who was doing it. So if had it been somewhere intramural,
more important.
yeah, and you see it in the
Patients outside
adnexa.
stimulated. Like patients have been stimulated from outside and they just land up within
Exactly,
discharge of
yeah.
IUI.
And basically IUI stimulation are seen by the other set of people, and for them to see a cervical fibroid posterior broad ligament entering the cervix, so that was a very rare fibroid for us also to see in such a way.
I have a question from all the North Indians. Ever since this is the North India side, I am recently facing a lot of problem regarding donor semen samples. They are such atrocious samples that I really feel I'm not doing anything only. So is it something common?
Even the quality of the semen sample has really gone down. And even
Donor semen, I'm telling, from the donor banks.
Semen samples are bad now. There are two reasons. One is the environmental toxins. We cannot ignore them. Secondly, the younger generation is on the drugs. They are smoking and everything. So that is causing. Thirdly, if we are getting from the donors, they are, I think, diluting and giving us the samples. So those samples are also not good when we are getting from the agencies.
And also we are short of the donors.
Yeah.
We are short of the good donors nowadays because they can just donate once.
Right now,
we have literally stopped our donor IUIs, at least in our center. Basically, because of that, we had a person in Chandigarh only. He's giving donor sample. Yeah, something. Yeah, and honestly, the quality of the sperm they give even for our IVF cases or in our IUI initially were so bad, and they cost around 8,000 rupees per sample. And they say that they will get it transferred. They have their branch over here. They will give us some kind of story. But honestly, when you look at the sample, it is a worse than it is a severe oat sample. So it is actually not worth it. So we are a 0% donor cycle in our center.
In some affording patients, at times a few HIV couples come in which you cannot do IVF. So in such patients, you can counsel them that you pay for 3 samples, we'll do 1 IUI by pooling them. That is one thing in serodiscordant couples I have started doing, because you don't have any option. You don't want them to, be subjected to IVF and like that. They are like lost to you. So that is one thing that I cost. The cost for 3 samples is 16,000 and 1 sample is 10,000. So we tell them you pay 16,000, we pool all 3 and then put in 1 IUI.
How can that would be
the sample is from one
donor. They give 3
How do you
samples.
know it is one donor who's giving 3 times? Like,
I don't know if he has given 1 time and they're giving it in 3 vials or whatever.
They take the sample once and they cryopreserve it in different vials and they send you together.
Yeah. Normally they give us 2 samples. When we ask for the sample, they give us 2 cryo vials, because most of the time, maybe the first one is not proper, then at least you can thaw the second one.
They're not giving now 2 samples.
Ma'am, अब तो हमें तो दे रहे हैं. From the ERT bank, we are getting 2 cryo vials.
Yeah.
And
not storing them.
What I'm doing now is, because of the high cost of the samples, I am asking them to divide into 2. If the patient doesn't conceive in first cycle, they will give me a second sample also, but they divide the first sample into 2 samples, because they have to now document each and every sample. So that's why if they cannot give us 2 samples, but if we give them that the first sample patient did not conceive, then they do give us the second sample then. Otherwise, the cost has gone very high.
Yeah.
So one thing more I wanted to share with you all was, because the discussions were going on, when the cervix is not negotiable. I had one patient where it was absolutely S-shaped cervix, and you could see it in ultrasound. I could not do it under GA at all because the cannula won't.
Next time one has to do laparoscopy and cut off those.
Nothing could be done in that case, and I tell you what happened was, I could negotiate it with Foley's catheter, because I normally do sono-infusion sonography. So in that patient, I did it with the Foley's catheter, and that went easily. So we can use the IVF catheters in these patients then, where they are not negotiable by other catheters. Normal catheters sometimes don't go.
Right. And Dr. Seema, you do mock ET in all your IUIs?
No,
mock ET
No IUI. No IUI. IVF, most of the cases, we
are doing every case, but in IUIs, we can never know if it is the first.
No, IUI we don't. The speculum examination tells that this case has a normal healthy cervix and she will not require. And the scan also shows. But somewhere, if she's a previous CS or something, then definitely we try to negotiate first. Not all patients in IUI, definitely.
change the pregnancy rate
Usually the patient only comes up with the history that I had an IUI over there, but that the doctor had a lot of difficulties. Even if you have IVF cases, you get patients that they could not transfer. They have frozen embryos over there. It was a difficult case. So usually they give a very particular history. They are smart enough to give this history very honestly. Rest of the history they might not give. So
Yeah,
at least in
IVF,
these
we go for
cases,
hysteroscopy routine as far as
yeah,
possible.
I
We
think.
try to do hysteroscopy for all our patients before IVF. So that makes our job easy. IUI is simple. Looking at the cervix, you can make out that there is a problem, and let me see if my dilator can go in. So not at anything else, but 6-number dilator simply they can put.
Okay. So I think that was a genuine sort of a discussion that we had on IUI right from.
This we can have more often, Dr. Jyoti. I think we should have these clinical discussions amongst ourselves. So it's good.
Yeah,
at least
we
we
can
sit
Comfortable discussions.
very comfortable.
Very fruitful. So
We
thank
should
you.
share our own experiences.
Yeah.
That is more of helpful rather
Right,
than.
ma'am. Very right.
Yeah.
Thank you so much. Thank you, Dr. Niharika, for being moderating such a so efficiently, and thank you all the panelists who have been so very instantaneous and so very informative and practical.
Yeah, so
And,
special thanks to Dr. Jyoti. She has made such a wonderful slide. I mean, if you read it, you will at least get the 2-3 slide तो आपको लगेगा ये notes में लिख देते हैं.
मैंने
इतना अच्छा मैडम
screenshot
ने
ले
slide
लिया.
बनाए हैं बहुत ही. And thank you panelists, such a well-read panelist. We were, I mean, a very the discussion has gone to anything, everything, and with such crisp discussion, that is the best thing out of the panel. Thank you, everyone. Thank you.
Thank you, our moderators. Thank you so much.
And over to Dr. Monica now. Dr. Monica and Dr. maybe I don't. And Dr. Shatabdi.
Yes, ma'am. Yes, ma'am. I'm there.
Yeah, yeah.
Thank you so much, ma'am. That was indeed a very, very nice elaborate discussion.
Monica has left.
Ma'am, Monica I think had to go for some emergency, ma'am.
Yeah. So
She was
anyway,
there for
thanks
some
to
time.
both of you for making this webinar possible.
And
Thank
also
you so
Dr.
much, ma'am. Thank you, ma'am.
Dr.
Good to
Priyankur
have
is
you.
chairperson PAC, no? Dr. Priyankur is
Yes, ma'am.
Yes. Of course, congratulations. Thank you to him also.
Thank you.
Thank you, ma'am. I'll convey your wishes, ma'am, to him. He also is, I think, out of station. He's not in Shiliguri. He was
It
traveling.
was actually because of Priyankur we all have met and had the best of our time. So thanks to him also.
Thank you so much,
Thank
Dr.
you.
Nihal.
Thank you,
Thank
Dr.
you all.
Jay, for moderating it so nicely. Thank you so much.
Thank you, Dr. Niharika and everybody. And thank you, Dr. Monica, PSC committee, and Dr. Jaideep, sir, for giving us this opportunity. See you again on some platform soon, because we meet on these platforms only these days now.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. Thank you. Thank you to both the speakers and both the moderators. It was a lovely discussion. All the panelists for taking active part. And a very good night to all of you. Hope to see you all very soon. Thank you all. Thank you all once again. From the entire PAC committee, and thank you, Corona.
Thank you, ma'am.
So Dr. Monica could join in the end, huh? Dr.
Yes.
Thanks,
Monica, you can officially give the vote of thanks since you have joined.